important, the place and the people, risk factors. It's very important in the disease control. For this study, this is the first population-based the study across the state, and also very few studies based on population-based. There's some studies conducted by Stanford and New York, but usually they're using the spatial population, not across the whole community. So this is one of the importance of our study. You have the brief about the results, but I would like to appreciate the very impressive the teamwork across the institutions, the collaborations among different the units, and also appreciate the opportunity to work on this to help the community. And also I'd like to thank you for the Washoe County residents who participated in this study with us. Thank you.
All right, thank you, Dr. Yang. I'm going to post the press release in the comments section if anybody hasn't got it. You can read it real quick. Right now, we'll give it to Heather Kerwin, Epidemiology Program Manager at the Health District. Heather, go ahead.
Hi, thank you, Scott. Really, what we wanted to determine was we knew that there was not really a coherent testing strategy that was being done nationwide early on. And so we knew just by our own experiences here at the Health District that throughout all of February and in even the latter parts of January, there were persons that were returning from high-risk areas that had been exhibiting, symptoms that were COVID-like, and we would have to go through a very nuanced step of trying to call CDC and ask for permission to be testing these individuals. And we know nationwide in some of the studies that have come out now that there were infection and transmission chains that were completely missed earlier in different pockets of our country back in February. And so this was just another way to help provide some data behind how many of those infections may have been missed earlier on or who had immune response due to a earlier infection. So it, as Dr. Yang said, it definitely helps us build and provide an additional data point on, the number of people who have been infected to date by that June 10th date that we finished wrapping up the testing. So it's helpful from that perspective. And we know that in our communities and across the nation, in all infectious diseases, that you're really always only looking at the tip of the iceberg, that you don't usually have 100% of all cases reported for any kind of condition. But it's helpful over the course of time to understand how much underreporting there is historically given each disease type. And we did compare, our study to some of the other studies that Dr. Yang mentioned, also in California and other areas of the country, where based on their estimates, they're thinking, there's 65 to 85 times more cases. And here our estimates are showing 4.5 to 5 times the number of cases, which is really a testament to the amount of testing that we've been doing and our ability to work so closely with our Nevada State Public Health Laboratory, who did finish their validation well ahead of other public health state labs across the nation to be able to provide this test locally while other commercial labs were still catching up and being able to provide the testing more widespread. So I think we've done a great job at testing people in our community who have needed that testing for COVID-19. And our estimates, although of course 4.5 to 5 times feels much larger, it's definitely not as underreported as other communities have found through similar studies.
Okay, thank you, Heather, for that, and Dr. Yang. Now we'll open up to questions for Dr. Yang and Heather. Go ahead and feel free to just speak up and ask your question. If you don't have a microphone or if some audio issue is occurring, feel free to leave a question in the comments, and then I'll address those at the end. But go ahead and fire away, guys.
Anything, this is Siobhan from the RGJ. Anything about this study surprise you? What was the most interesting takeaway for you?
It was not a surprise, but we never done this. Based on our previous projections, we thought it's between 2 to 5%, but the results still we're anxious to know where we are. So that's the importance. That's the reason we want to conduct this study.
I think the only element that surprised me, because we did couple all these antibody tests with a PCR test, which is that molecular test that looks for the more acute infection. There were absolutely no positives out of that, so no one was acutely infected either. So it was good, but a little bit surprising as well.
Kind of explain that. What do you mean no one was acutely infected? Explain that.
So we coupled the antibody test, which looks for a more historic infection or a longer infection, because the antibody test is looking for proteins in the bloodstream that develop as a reaction to an infection. It's an immune response. And so you're looking to see if those markers are in the bloodstream, but we didn't want to miss anybody who was acutely infected. So we also coupled that with the nasal swabs that everybody is getting in the community through our normal post, our drive up post, so that we wouldn't be missing, let's say if they had been infected and actually were sick at the time, more in the more recent weeks, like 1 to 2 weeks.
You can't tell how far back someone may have been sick with this.
Correct. Not with this type of test, unless you take blood specimens and then you test them, over a course of time.
What's a study like this look like? Like we saw what the health district released. Is it like, hundreds of pages of data and then you break it down to what you found? What's the study that the scientists are looking at? What's that look like?
Dr. Yang did a lot of our analytics, so I can have him touch on that and then circle back with anything.
Yeah, our research team, we had intensive discussion and study and literature review, try to capture any potential risk factors will help us to control the disease. We try to collect as much information as possible, so we have a long study form for the subject to fill the information. But at this point, we are doing the more detailed, deeper analysis as much as possible. But at this point, this is just the first phase of study. The study power may not allow us to go too much deeper at this point. But the information is here. We're going to accumulate the information for the further analysis.
What other stuff do you want to find out from this study? What are some things you think you could find out from this first study?
Any potential risk factors, such as you have a contact with risk group or people you already know, diagnosis with the disease, what type of job, have you traveled internationally or across the country, and if you are in healthcare and a high risk industry, and the symptoms, we ask the symptoms. What else? Also, we have demographic information.
Hi, Mary Hines with the Review Journal here. Can you tell us what the public health implications of these findings are?
Kaiser?
Yeah, so really, it definitely tells us that there are more infections out there that are either so mild or persons are completely asymptomatic, or for some other combination of reasons, people are not seeking testing, which, as I mentioned, is pretty traditional with a lot of communicable diseases. There's a lot of disease that goes unreported because we rely on a test to be able to determine what's making someone sick. And so it just tells us how much of our population is being missed by testing. And in terms of like the case fatality rate, because we now have a better estimate on our true denominator of the population that's actually possibly had been infected to that date. We also balanced that with our known deaths, which are usually better captured. There's always going to be a little bit of a report delay on deaths. And then, of course, we don't fully understand the set of circumstances that could cause someone to pass after having been infected with COVID. But it helps us better understand that the true case fatality ratio is much lower than what our current case fatality ratio is showing, because we have a better understanding of what that denominator looks like, knowing that that numerator stays the same. And then, of course, the big question that I think a lot of people are wondering about is the herd immunity, which ideally you need to have 60 to 70% of a population have had an immune response, a historic infection, and then a longer lasting immune response to a pathogen before that pathogen will kind of taper out naturally. So we're very far from being anywhere near herd immunity, which we knew inherently, but it's nice to be able to back that up with actual data.
One of the importance for this type of study is to understand the current burden of the community and to help prepare and plan the public health workforce and also healthcare systems, how we prepare that. And also it's good factor, good information for the disease projections. Where's the pattern, where we're going to go. It is important.
Thank you.
We do
Hi,
hope to repeat this. Oh, go ahead.
Oh, no, keep going. I'll ask when you're done.
I was just going to say, we hope to repeat this study every 5 to 6 months, and then we can use the metrics from this study and compare it to the next phase, which would be 5, 6 months from now, and look at that change and see again how it's growing and how quickly it's spreading in our community as well.
Hi, this is Denise from Channel 8, and I think you just kind of answered this, but there's perhaps more. What is this information going to be used for, turning it into action? And the next thing is, finding out that infections were maybe 5 times higher than we thought. Could that lead to any changes down the road, or any potential policy proposals or anything like that?
I think the contribution of this type of research across the country might help inform policy changes. But here locally, we're going to be in lockstep with our state, which is, we're trying to get behind CDC guidance and really start approaching this nationally, which is what we would do for other communicable diseases. So in terms of different policy here locally, I don't think that anything gleaned from this study is going to be used for any local decisions at this point. But down the line, it may be, and it definitely helps contribute to the body of knowledge for a more standardized regional or national approach that might be used in terms of changing what we're doing in regards to how we work with this virus from a public health standpoint. I don't know, Dr. Yang, if you have anything else that you'd want to add to that.
Talk to me, Heather?
Yeah, I don't know if there's anything else that you would like to
Right.
add.
Right. I think there's several messages. I mean, the results is here that implied for the positive side is we know more cases are asymptomatic. So it's kind of more mild. People may not seek for the care, and so they are not diagnosed until participate this study. So that's the good part. And also the case fatality rate is lower than what we understand between just among those confirmed cases. Also, another message is for the general residents here is lots of people may have disease, don't have this asymptomatic, but they can still spread the disease to the high risk people. If people have the immune compromised or seniors, there's still high vulnerable population, but people will have more of those asymptomatic residents than we thought. Those people can still spread the disease and set risk for those vulnerable people.
So you tested 234 in this study. So break that down, just numbers for me. How many did you find had it? And then how many of those were asymptomatic in that 234 group?
So there were 6 who came back positive for the IgG antibody out of that group. And among those, there was 1 that recalled being sick. And the other 5 did not. However, when we do our investigation of cases, the health district, when we're talking to our confirmed cases, a lot of people are still thinking of just like the fever, the cough, those really traditional shortness of breath as the symptoms. So we would need to do a further interview with those other 5 people who didn't recall being sick and see if they experienced maybe GI illnesses or headaches or even really mild symptoms that could that we would count as having some signs and symptoms of illness, as opposed to people who truly had absolutely 0 symptoms. So we would need to really talk to those 5 individuals who claim they had no symptoms to know if they were truly asymptomatic or if it was just mild symptoms or a different combination of symptoms that they didn't perceive to have been symptoms.
Yeah, since Heather mentioned those numbers, if you simply put these numbers together, the numerator, denominator together, you may find it's not exactly the percentage. The reason was because we did the weighting for the representative of each blocks, and based on the weighting, then we have those scientific based on the weighted prevalence.
So it was 6 positives, but because you weighted it differently, that's how you came up with the estimate of 4.5 to 5% likely are infected in the community. Just not understanding the math exactly.
It's a 2.3 weighted, but if you did just the pure like dividing, then you wouldn't see, you see there's an unweighted and then there's weighted, and we provide the weighted because Dr. Yang balanced our studies demographics based on race, ethnicity, age, sex against the population of Washoe County to make sure that basically you balance it out, that maybe we knew we had underrepresentation from a certain age group or a certain race and ethnicity in our study, but by weighting the data, you bring it back to, okay, well, given that this is what we found in our study, this can, be representative of the county's population because we have those numbers.
And that's how the Hispanic population being underrepresented then changes the weighted number, because you knew that population was more affected because you didn't have enough Hispanics. It made the number higher. Am I understanding that right or no?
Yeah, so we did consider the weights. Give a Hispanic population, they about 10-11% participated, but they carry more weights than the other group. The 2 numbers here, one is a 2.3% infected, so that's the results. Then 4.5 to 5 times higher number was the number of compared to confirmed cases and the projected cases we have.
Hello, this is Scott Sonner at the Associated Press. Appreciate you explaining this. Just to be clear, this doesn't suggest that the numbers we've had, the case counts, there's anything inaccurate in those. This just tells us that the number of confirmed cases that we have are not as representative as perhaps we thought of how many people are really infected. Is that right?
Correct. It's a little hard to hear you, but if I understood your question, it's not that our current cases that are displayed, say, on our dashboard or that are released every day are wrong, because those are known to be confirmed with a diagnosis of an acute infection. But by looking at the antibody prevalence in a population, you can extrapolate that number back to the entire population and say, this is how many estimated number of cases we think have actually happened to date. And in part because of all the challenges I discussed early on with getting testing done back in February, and then even standing up widespread testing in March. For example, if we were to have tested 100% of residents back in March, and then therefore everyone who tests negative testing 100% of the population again, our estimates are showing that they're with a margin of error, that this could be how many positives we would have found if that were a feasible way to be testing for this.
Yeah, so the population is there, but it's impractical to test everyone. So the purpose of a sampling, all the sampling process, is try to make sure the study as representative as possible. So we started from the sampling using very scientific process until we have non-responding, missing cases. Then after that, we do the weighting. So all the process are highly scientific based. What we're trying to is using this sample to represent our population as much as possible.
Anything else you can glean from the data? Like, did the 6 travel? Did they not travel? Is there any other things, insight you could give us to the random study? Or are those just things that will come out later?
I'd have to go back and look at their actual surveys. I don't believe there were only 2 that had traveled. Neither were international. They were domestic. And I'd have to look at the others to answer that accurately. We know that definitely early on travel was a risk factor for just being on a plane, and then coming and going from some more hotspots or international or domestic hubs, that was a risk factor early on. But now that it's community-based transmission in almost every community across the country, that's probably less indicative of a risk factor moving forward.
And can you talk about the 234 and how that is a good statistical number?
Okay. Yes. We would start from the design stage. We need to based on the minimum efforts, minimum resources used, but the maximum representative, and give you the confirmed the results. But this is we designed and based on the projected prevalence rate based on the other different factors, our population size. We think 197 is our projected, the minimum sample size we need to make conclusions. But as the good questions you just have, to go details, is it travel, go to the race ethnicity. If you go to that detailed, we need more study power. But at this point, 234 is, we feel very confident with our margin of errors. It's within our research design, yes.
Will the future studies you do have more people in them, or will you aim for that amount?
Hopefully.
We hope to have more. It's always better to have more for the most part in these types of studies.
But again, as I mentioned, the efforts is unbelievable. There are National Guards, there's so much organization, many people and behind supported different agencies. But in the future, if the resources are available, of course, we try to do as we can design as much subjects and as big as possible. But at this point, yes, depending on the research questions, we meet our requirement.
All right. Maybe we have time for just a couple more questions. We still got Kevin Dick, who's going to give a COVID-19 update. But are there any other questions for Dr. Yang or Heather Kerwin? All right. Hearing none. Thank you both very much. As Dr. Yang said, yeah, it was a tremendous effort, and we want to just thank everybody from the University of Nevada and also the Nevada State Public Health Lab for all their help. Okay, we will transition now to Kevin Dick, the District Health Officer, who has a COVID-19 update in Washoe County. Go ahead, Kevin.
Yes, thank you, Scott. And I just want to echo some of the comments. This was really a huge effort and a great partnership between UNR, the School of Community Health Sciences, the Nevada State Public Health Lab, the Health District, and all of the people that assisted with the huge specimen collection for this that occurred with the National Guard and our MRC volunteers, CERT volunteers, and our own nursing staff. So it's great to see this wrapped up and the results coming out of that. As far as the case count update today, sadly we're reporting 3 additional COVID-19 related deaths in Washoe County. We have a male in his 80s with underlying health conditions, a male in his 90s with underlying health conditions, an additional male in his 90s with underlying health conditions that have passed away from COVID-19. So that brings our total COVID-19 deaths in Washoe County to 85. Additionally, we have 47 recoveries that we're reporting today, and we have 33 new cases of COVID-19 in Washoe County. I would mention also that we're expecting to get additional lab results in today. We'll roll those into the case count that we provide an update on tomorrow. So we may have additional cases occurring. Since the last press briefing, we've had some very high numbers of COVID-19 cases reported in Washoe County, with a record high of 150 cases that we reported on Friday, July 3rd. And so our 7-day rolling average has increased significantly to about 75 cases per day. To put that in perspective, I'd like to remind everybody of when we thought we had reached the peak of this phase 1 surge, that was at 32 new cases reported a day. So we're well over double that at this point. The number of cases that we have recovered, let's see, I'm sorry, let me give you the total COVID-19 cases in Washoe County today. These are the PCR confirmed test results. 3,328 people tested positive to date. We have 2,170 recoveries, and we have 1,073 active cases. So, one of the utilities of the data that we have from the seroprevalence study is you can look at that number of 1,073 active cases and estimate that we probably got in total 5,000 or perhaps more active cases in Washoe County right now, based on our understanding of approximately 5% of the population or five times the number of our confirmed tests that potentially is the population out there that have COVID-19. The currently hospitalized cases are at 88, and we have 244 individuals that have been discharged from the hospital. Our bed capacity remains good in our hospitals. The Nevada Hospital Association is reporting 78% of our acute care beds are occupied in Washoe County. 58% of our intensive care unit beds are occupied, and only 23% of our ventilators are in use. So those are the numbers for today. I think it's important that people recognize that we're nowhere near herd immunity. And fortunately, we don't have the proportion of the population that's been exposed to COVID-19 as has been inferred from some of the other seroprevalence studies that have occurred in other parts of the country. But we should be sobered in our understanding that we could have 5 times as many cases out there. And so that's with a high number of new cases being reported daily, and that understanding, people need to understand that we are nowhere near out of this. We are right in this battle with COVID-19, and everybody should be aware of the precautionary measures that we've been advising to prevent the spread of disease, and understanding the importance of their role in our community if we're going to be successful in moving through this. So that's my briefing for today. Be happy to take any questions.
Go ahead and answer questions if you guys have them. All right.
This is Siobhan. I'll ask one if nobody else has one. Any comment on a lot of the, it seems like a lot of the numbers are younger and younger people being diagnosed or testing positive for coronavirus, and what's that like? Do you know what that's like compared to some of the hospital admissions, or at all? Is it younger people?
I don't have data on the hospital admissions and who, what age group that is. I think we know that while the percentage of the younger cases that develop severe symptoms is smaller, we also know that we have young people that are hospitalized from getting COVID-19. So I think what we're seeing is probably a result of some of the younger population that is out having more contacts in the community, potentially going to gatherings that we are advising them not to, where they're being exposed more to other individuals, and we're seeing that disease transmission occur from that.
And this is Heather. I can speak to just a little bit about the hospitalizations. We traditionally see people who have underlying health conditions, whether that be diabetes, another condition that may impact lungs like COPD or asthma, being a predominant reason, shortness of breath, people who have, a history of things that are impacting the respiratory system are those who present to the hospital more frequently, and then they have that longer stay, usually anywhere from about 4 to 6 days, but it's normally those who are 40s, 50s, and older. The younger ones who are hospitalized usually have some very unique autoimmune or other underlying health conditions that predispose them, again, to those negative health outcomes related to once they already have a COVID infection. So thankfully, we haven't seen a big rush of our 20 and 30-year-olds ending up in the hospital. And if they do, they usually kind of bounce back pretty quick and then are discharged relatively soon. So that's good. And I know our hospitals have been not as quick to intubate persons, which is great because intubation is kind of the last step that you want to resort to. So they've been finding a lot more success just putting people on oxygen and those nasal cannulas as opposed to venting them right away. And that's, I think, helped drive down some of the negative implications from when you do have to put somebody on a ventilator.
Hi, this is Jeanette from the RDJ. Kevin, can you talk about the criteria you're using as to watch the hospitalization rate increase? Yesterday, the state said it would be up to local health officers to determine when to implement expansions of hospital capacity. So obviously, we still have room and capacity, but the hospitalizations are increasing pretty dramatically from the time we reopen. So what are you looking at? What's kind of that threshold for when we say, hey, we got to open up more capacity?
We're watching the numbers, and Jeanette, thanks for the question. when you look at the numbers as far as the hospital utilization and the COVID cases in Washoe County versus Clark County, our numbers are much better and lower than what Clark County is experiencing. But we're concerned that we may see an increase in those numbers as we move forward. So we're watching those. But at this point, I don't think that we're anywhere near the place where we need to be building surge immediately. And it's comforting to know that Renown took the proactive step of building out their parking garage structure, that first floor, to provide 700 additional beds. And so that is available as well. But we're watching the numbers, and there's not a bright line. I think it's looking at the new cases occurring, as well as the number of hospitalizations, because you've got a lagging indicator with the hospitalizations. We expect to be following the new cases, but we're also watching, are we getting less hospitalizations, because it's younger people that are the majority of new cases.
Hi, Kevin. This is Laura from Reno Al Dia, digital newscast in Spanish. My question is, does the health district provides the businesses who had positive cases saying, hey, this business is already clean and not at risk for other employees and for other people who go to those businesses?
I think, thanks for the question, Laura, but I think that maybe is one that Heather may be best prepared to answer.
Sure. So for businesses, we're really still looking at that direct person-to-person contact. Sorry, I'm going to turn my phone down in the background. Never stops ringing. So we do notify the businesses, but we are not going to say, you know, you happen to be in a grocery store and there was someone who was infectious in that grocery store, and if you happen to walk down aisle 10 at 11:45, we can't get that precise, and that would just absorb all of our time, and we wouldn't actually have time to do our case investigations with all of our cases. So the businesses are provided materials on how to do a deep clean. They're provided materials and how to exclude those who may have been exposed. But we're not looking for, you know, did you happen to walk down the same aisle as individuals? We try and look at healthcare providers, places like if you were in the waiting room at the same time as somebody, that would be one that we would notify the healthcare provider and obtain patient information and then do our regular contact tracing. But at this time, that's why it's really important for people to be wearing masks and for washing your hands, because you can touch a gas pump, for example, and it could have COVID viral particles on it. So it's just really important to continue to do as much as possible to protect yourself and others.
Yeah, because I've seen some signs saying that this business is closed because it had a positive case, or it had some dealing with COVID-19. I thought that maybe when a business reports that there's been more than one case, because usually there's like more than one case, you guys provide some type of like sticker or something saying this place is clean, or something, that they went through the cleaning process, that you guys already looked into it, or something like that. That was not that they go to any or anything.
So in these instances, it's whether a business is actually going to be impacted by being able to keep their business open based on the number of employees who are exposed to a positive or multiple positives in the business. We're really trying to work with our business partners in our community and not being you know, like you have to shut down, you had a positive, but balancing out, are you able to safely still run your business, or is the number of people who are exposed going to prevent your business from actually being able to run? And you know, we do inspect places that we do food permits, and OSHA is inspecting in places that may not be compliant with mask wearing. But it's really on a case by case basis, and every single business and every single place that's got public visiting it or just anywhere should be employing the practices of sanitizing and more frequent than normal disinfection of high touch surfaces. So we would be expecting that all businesses and all public places and private businesses are implementing that on their own already.
Was, as I've heard from people, many people have called us and saying that they're not following. So I think we should do something about it.
Mm-hmm. And there's a
Thank
number they
you.
can call OSHA to put in any complaints.
They already did.
Okay.
Uh-huh.
If I could follow up on that, Laura, also, as far as a sticker or something that would be saying that this business is clean, it's okay now, I think that would be providing a false sense of security for anybody that's visiting a business. I think that what people need to understand is there's no place that's truly safe. We're taking these precautionary measures. Places would be safer if everybody complied with the governor's directives and everybody was wearing masks. But even then, there's a risk, and so people need to understand that any business that they go to, there's a risk involved in that. Any person that they visit, any home or private gathering, there's a risk involved in that. So I think we need to be careful that people don't have this false sense of security. And I think that's one of the reasons we've seen a rise in the cases is that we had the reopening and we had, all this publicity and footage of casinos reopening and the celebration around that. And that lulled people into a false sense of security, which resulted in more spread. So I think it's important people understand there's no place that's safe as we move through this COVID epidemic, and we need to all be careful.
Okay, thank you.
Any further questions for the group? All right. Thank you again for joining. If you guys have any questions, feel free to reach out to me. We're continuing to send up our updates via Twitter, our website, covid19washoe.com, and through our COVID-19 dashboard, which can be found on covid19washoe.com. Have a great day.